Further to what David said, I have some Glasgow connection. I was born in India, I grew up in India, but my first job was in air. I worked there for 6 months as a house officer, but that was 35 years ago. So I'm afraid I've lost my Glasgow accent. So if you have any difficulty, please do not hesitate to raise your voice. And as David said, I've had quite a long link with Haemochromatosis Patient Society, which I've really enjoyed. It has benefited me in so many different ways in shaping up my service, which I'm going to talk about a little bit. There are two bits to my talk. The first part, the second part is actually the main bit, the question Q&A hour. So feel free to ask questions. I've got quite a few extra slides. I'll put them up and I'll talk around those slides. If I haven't got any answer to your questions, if you give me your email, I promise I'll come back to you with my answer. Which means the first half, I'm free to do what I want. And I'm going to tell you some stories. I'm recently become a grandfather. I'm going to be the second one on his way. And I'm preparing myself to spin and tell stories, which I'm going to do to make a start. Now, hemochromatosis is all about story of iron. And I find this very, very fascinating because it is one of the things that links up with everything else. And I'm going to expand on that point. I'm sure you're all familiar with this picture. It's probably one of the most quoted image from the Google worldwide. Such a beautiful planet we live in. And this, if you go back to the story, where did this all come from? Where do we all come from? Where is the shared link between the human being and the world around us? And iron is the center of all that. And if you all remember, some billion years ago, there were protostars. And these stars were enormous stars. So much so that these stars couldn't just hold their sizes. And as the fuel ran out, they all imploded. And they died a black hole, or they then burst into supernovas, creating billions of temperature. And at those temperatures, the stable iron that we see, the platinum, the gold, the silver, and all the big elements were formed. And we are carrying all those things that from the supernova in our blood. There is so much of iron in the universe. As you know, our core, our mantle, and a quarter of our Earth's crust is iron. And this is a little story. Can you recognize this place? Well, it could be anywhere in this world, but this is the Yellowstone National Park. This is where the 4 tectonic plates meet. This is where you get to see the supernovas, supervolcanoes every 300,000 years. Now the red ponds are actually bacteria or algae laden with iron. There's so much of iron within these organisms. There's unimaginable quantity of iron. But if you look at us yourselves, you and I, carrying only 3 to 4 milligrams of iron, not a milligram more, not a gram less. If you're a gram less, you'll become anemic. If you're a gram more, you become iron overloaded. How does the body manage to maintain such a sort of a small concentration of iron within that limited range, given that once iron gets into your system, it can't get out of your system? The only way for iron to get out of your system is by blood loss. So the magic is here. It's inside of your small bowel. Now, you can see the endoscopic picture on your left and the histological picture on your right. These are villi and the crypts. Now, the cells right at the base of the crypts are the real cells. They are the sensor cells. These cells, they have on the base the sensors which identify how much of iron there is in circulation. And as they identify that the iron is low, they will switch on the transporters. And these transporters, or cells laden with transporters, will then migrate to the tip. And this is where iron absorption will take place. that iron that you and I eat or take or consume, it's in two forms. Most of the iron will come from the heme, which is the blood, the flesh, liver, kidney, muscles. That's where it comes from. It doesn't require any transporters. It goes straight into our system. So in other words, if you become anemic, the best form of treatment is red meat. I, through all my working life, have been fighting with our medical colleagues not to prescribe oral iron. Oral iron is very toxic. I'm sure you have noticed, if you take iron, sometimes it gives you tummy aches, it gives you diarrhea, it gives you vomiting. And we physicians, we are very slow in changing our clinical practice. We still sort of prescribe iron with oral iron tablets willy-nilly, and some of our elderly patients are on iron tablets permanently. And I think that's a wrong clinical practice. We physicians should wake up and move away from. There are better ways of giving iron. So the heme iron is the best form of oral iron if you want to have iron treatment. If you're iron deficient, girls in the puberty, girls, menorrhagia, pregnancy, best form of treatment is oral is meat. The other iron is the vegetable iron. Now this is where the problem is. Unfortunately, the vegetarians, I can understand they are always at risk of iron deficiency. Now this is where iron absorption is very complex. The iron that we take is in the form of ferric iron, and that has to be converted into ferrous iron. And there are some enzymes at the tip. They're called ferrochelatase. So they're converted into ferrous iron, and then ferrous iron binds to the DMT1 transporters, go through the cell, and then sit inside the cell for some time. If the body needs iron, it will come out from the base. So I've used two triangles. So the apex is towards the lumen, and the base is towards the blood vessel. So there are some transporters towards the base, which are receptors, which are sensors, and if you are iron deficient, that will take the iron out of the cell through using a transporter called ferroportin, and I'll come back to that again. This is a emerging knowledge and information about ferroportin. It's going to be very, very complex protein, and more diseases will be identified around this molecule. So the ferroportin, when they transfer the iron to transferrin, the transferrin will take the iron to everywhere. The most important destination will be liver. Liver will extract the iron from the transferrin, push it inside the liver cells where it will sit. Now in hemochromatosis, before I go to hemochromatosis, as the iron gets inside the cell and it becomes overloaded, it will send a signal called hepcidin. Now that's the other word I want you to remember. It's a protein called hepcidin. Now hepcidin is the signal. The body is sensing that body is full of iron. The hepcidin will go into the intestinal cells and will switch off iron transporter. So look at the way body is regulating iron absorption within these villi. And these villi are so tiny that you can't even see with the naked eye. You need a hand lens to see. And there are millions and millions of villi within our small bowel. And the body tries to regulate iron absorption through these villi. Okay? In hemochromatosis, where things break down, is the sensing apparatus has gone out of gear. The sensing apparatus has gone out of gear. So even if the liver is full of iron, liver fails to synthesize hepcidin. So the iron absorption from the intestine continues. And you get more and more iron absorption, more and more iron deposition. And this iron in turn triggers scarring. Scarring leads to cirrhosis, and which enhances the risk of cancer. Now, I'm going to use a patient's journey. If I stand back, okay. Can you hear me there? Now, I'm very grateful. This gentleman is no longer with us. He was one of my first patients at Stockport when I started this program 20 years ago. His wife has very graciously and kindly allowed me to use his case history as a talking point in these talks. So when he first came to see me, he was 68 years old, gentleman. He used to work in the Air Force, enjoyed a good quality of life all along, except for a past history of ankle swelling. Now I'm going back to 1997 now. Now, at that time, this history did not raise any eyebrows. It went on. He started complaining a few years later of leg pain. And he was referred by his practitioner first to a cardiologist, thinking that it could be vascular pain, who did angiogram, found everything normal. Then he was referred to a neurologist, who did all the neurological tests, nerve conduction studies, and they were normal, except that. So he went round and round through so many different hands until I don't know why he came under my care when he started to complain of tiredness. Now, the complaint of tiredness is not often spontaneous. You have to dig that history out of the patient. And men generally don't volunteer this information unless they are confronted. And everything started to fall in place. So ferritin came back as very high. And at that time, the gene test was just becoming available. It was costing the hospital about £50 to do this test. So I had to sort of, literally sit on my knees to get this money out of our division. And he was tested strongly positive, and his liver biopsy showed that he was cirrhotic. He started having vivisections. He felt better with the vivisections. His energy levels went up. His liver function test normalized. And he kept a record of his own vivisection program. But the alpha-fetoprotein, this is oncoprotein. So this protein levels are high when we are kids or when we are sort of neonates, and then it switches off. But it again reappears when oncological or malignancy sets in. And there are certain malignancies like testicular cancer or liver cancer are known to cause very high levels of alpha-fetoprotein. Anyway, the alpha-fetoprotein levels are just sort of marginally raised. I don't think any doctor would sort of be too much worried, to get too much worried with that sort of a level. But being a person with an interest in hemochromatosis, from what all my reading, I thought that there was something happening. Is it just a part of cirrhosis, or is there a cancer setting in? But the ultrasound scan did not show anything. So, can you see the picture? Can you see his own record of ferritin, how the ferritin levels were coming down? Came down to baseline, and he was feeling better. But because of this small rise in the ferritin, I discussed matters with my colleague at Manchester Royal Infirmary, and he had an angiogram. And the angiogram showed there were not one, but two focal lesions within the cirrhotic liver. So I don't have a pointer here, but can you see the outline of the liver? It is a bit lobulated, which means the liver has shrunk. And can you see the white spot inside the liver, which is where this focal accumulation of the dye is the liver cells taking up the hot dye. So it's a tumor which is just very early phase of development. This gentleman he was not fit for liver transplantation because of his age and other comorbid factors. So what he had radio substances injected into the tumor. And that gave him another 10 years of life. So it was the early detection of the tumor that allowed him good quality of life another 10 years. So if I use that as a journey of hemochromatosis patients with complications, what did we do well and where did we not do well? So if I put the red bits are the things that we have done well. We did the gene test in time, we got the ultrasound done in time, the liver biopsy in time, we did vivisections, we screened the entire family, we provided genetic counseling, We introduced to the blood donation center for the follow-on donations, and we started to screen for cancer. And we kept a very low threshold for tumors. We discussed his case in the hepatobiliary meeting. We continued with the venesections for some time, even after the treatment. So where things didn't go well was why the early diagnosis, why it took so long for the diagnosis to be carried out, and why he had to go through so many hands before the diagnosis was made with certainty. So how can we improve things in, let's say, the setting up a district hospital, because most of the patients will be seen in a district hospital? Would NICE be the best way to move things forward? Versus, have you heard of Sequin? Now, this is Glasgow. I know it's not England. So in England, what the government is doing, they are tagging payments with quality measurements of any condition. So if you come with a heart attack, there are certain things have to be done before the hospital gets paid for that episode. So will a Sequin, a tariff attached to the quality care be of the way forward? Or would just giving a simple care pathway plan to the general practitioners be the way forward? Or there's something else which I'm going to talk about, was my way of improving things in Stockport, which I call Center of Excellence. Let's look at the first one. NICE, as you know, is a very powerful organization. NICE is almost sort of, it is as powerful as a Department of Health guidelines or legal thing. But for NICE has got lots of things in their hands, starting from cancer to heart disease to children to mental health. And if you put them in order, I don't think hemochromatosis will come up very much high up in terms of priority. And NICE is a scientific organization. They are not necessarily all doctors. They need evidence. Unfortunately, there is not much of evidence in the field of hemochromatosis. Most of the studies that have been carried out are in the United States, Australia, Canada. I have not come across any big multicentric study from Britain. There is a lot of variation in the phenotypic. Phenotypic means expression, physical presentation, physical expression of hemochromatosis. It differs from place to place. We are assuming that the hemochromatosis in the UK is exactly the same as Australia or United Kingdom or United States, because people migrate from here to different parts of the world. But that may not be the case. So we need a UK-based study, and we need to form our own guidelines. And that hasn't happened yet. Nor NICE is in a position to give its guidance for this. A, because hemochromatosis will be way down in order of priority, and B, there is no evidence. So what's the next thing we can do? Is payment to the hospital connected to quality of care. As I said, it has happened with heart, it has happened with chest conditions, septicemia, deep vein thrombosis, hip replacements. Can it happen with hemochromatosis? It has happened with alcohol. Alcohol, as you know, is one of the most important sort of a user of health resources in the district hospital, division of medicine. So there is aqua measure for alcohol, and as you can see, these are all time caps with things that should be done in a timely manner. Will hemochromatosis fit into this profile? No. It's a very slow condition. We're still not very sure if treatment does any good. Even venesection, there are people who sit on the sidelines on the fence and say venesection doesn't do any good. So there's no agreement. So I'm afraid this will not work for hemochromatosis.